With that, I would like to invite Dr. Giridhar. He's the director of Giridhar Eye Institute at Kochi. Please take note. Oh, they stopped it. Went beyond. Okay, but on that screen they used to have a timer, no? वो बंद हो गया।
ये है कि इसमें टाइमर
नहीं, उसमें वहाँ पे बंद हो गया टाइमर।
कहाँ
ऊपर वो आ रहा था ना इंसर्ट में।
गिरिधर।
इंसर्ट पे।
Yeah, that's right.
They stopped it. I don't know why. यहाँ पर वहाँ पे आना बंद हो गया। ब्लू में आ रहा है ना? That was not showing.
Okay.
Maybe
So, good morning and nice to see the hall slowly filling up. And after all those wonderful talks on various diagnostic modalities, I'll be talking on multimodal imaging. I don't know how I ended up in this session. But probably because we wrote recently a chapter in the Nima's book on multimodal imaging, which has had a very good feedback. A lot of people have sent emails saying that is quite interesting. Anyway, what I'm going to do in the next 10 to 15 minutes, you can stop me if I'm crossing the time, is basically to make you all understand how we can apply multimodal imaging in retina practice. It has become multimodal imaging, I think today has become an essential tool in the diagnosis, prognostication, and management of many macular diseases. And basically, what is multimodal imaging? Can anyone tell me what is multimodal? How do you define multimodal imaging? Can you tell me how do you define multimodal imaging? Multimodal imaging is presently defined as using more than one imaging modality for the diagnosis or prognostication of a particular disease. So that is actually the definition that has been given. More than one imaging modality. So you may use 2, 3, 4. So if you use OCT and autofluorescence, it becomes multimodal imaging. You understand? So with this, you got a whole array of diagnostic. You can see here OCT, which Dr. Rajendran spoke about, autofluorescence, Octa, which Dr. Unni Nair spoke about, and we are going to have some more talks on, we already had talks on angiographies, both ICG and FFA, which Jatinder spoke about. So basically it involves multiple imaging modalities, and you may not use everything in every patient, so you use what is relevant in a particular case. So with this introduction, I will just show you a few cases. Actually, I made this talk very recently in another meeting, and I'm just, changing the way I present this for for this particular session. Now, this is an elderly patient with a long history of wet age-related macular degeneration. The left eye is being treated. Now, can you tell me what you see in the OCT scan on the left side there? What do you see in the scan there? Quickly, what do you see? Okay, it's not CSR. No, that is basically a case of wet age-related macular degeneration. And why it is wet? It's good. It's either a CSR or a type 1 neovascular membrane. What you see is serous macular detachment, isn't it? But along with the serous macular detachment, you also see an irregularity of the retinal pigment epithelium. And in any elderly patient, 80, 82 years old, this is most probably a diagnosis of wet age-related macular. Now, what do you see in this particular photograph here? Quickly, because Rajendran will ask me to stop. Hypoautofluorescence. Now, what do you see in this particular photograph from top to bottom? What do you see? You see the area of hypoautofluorescence is slowly increasing. So, over a period of 10 years, the area of atrophy is slowly increasing, although the vision is more or less the same. So this is how we use multimodal imaging. So although the patient is doing well, we know that atrophy is slowly increasing, and that atrophy is slowly reaching the center of the macula. So autofluorescence is a very useful imaging modality to understand the functional status of the outer retina. Okay. So this is another patient. Now, this is a case I've already written the diagnosis. So good vision, elderly man. Now, what do you see in this OCT here? You see those small, only just now Dr. Anand Rajendran explained to you a lot of things. Now, based on that, what do you see in this particular OCT? Drusen. So, focal elevations, you must say. See, OCT is interpreted based on OCT language. From OCT, you say focal elevations of the retinal pigment. So you see drusenoid changes. Now when you see this autofluorescence, now this is an autofluorescence picture. You agree with me? Now from the top one and the bottom one, what is the difference you see? Top one, bottom one. What do you see? Difference? Hypoautofluorescence. So areas which were hyper earlier have become hypo. So again showing you that this patient also slow progressive decrease in vision he complains, but no cataract, but basically atrophy is increasing. So again, so autofluorescence is a very useful tool along with OCT to understand the functional status of the outer retina. Now this is the case number 3. Now what do you see in this picture? What do you see quickly? RP. So what is your diagnosis? So it looks like a case of a central serous chorioretinopathy. That's what I also thought. This patient requires central serous chorioretinopathy. Now I'm doing OCT. So first photograph CSR. Now OCT. Now in OCT, what is your diagnosis? You can see here OCT passing through that serous macular detachment. What is your diagnosis? So in the OCT also CSR? Looks like CSR or something else? So, pachychoroid, yeah, he's got a little pachychoroid and you see a little bit of an elevation of the retinal pigment epithelium, what we call as a FIPED or whatever double-layered sign, whatever you want to see, and that area is little hypertrophic. Now, I'm taking multiple sections. So, whenever you are having a machine and whenever you have a disease, you must analyze the OCT not with one picture, one scan, but all the scans together. Then, otherwise, you will miss something. Now, what do you see here? In the top one, what do you see? You see a PED. What type of PED can you tell? Peak PED, not bad. So you got a peak PED with a serous macular detachment. And when therefore what we did an ICG. So you titrate your multimodal imaging, color photo, OCT. Then you decide what to do, ICG. Okay? So now you do an ICG. This is a case of a polypoidal choroidal vasculopathy. Therefore, using multimodal imaging in this particular patient, we diagnose, you can see beautifully now, this is a classic picture, which beautiful pictures already Dr. Anand Rajendran has shown based on our work that we did many years together. So you can see that tall peak PED there. Now this is another patient. Now this patient actually, you can see here, he has had CSCR 30 years ago, very good vision in one eye, other eye, little bit of a visual problem. Now if you see the color photo, do you see anything here? Very difficult to say anything, right? You can't say anything much, but in my photo here, I see patches of suspicious serous macular detachment and patches of RP atrophy. So this is a case of CSR, right? This looks like CSR, nice serous macular detachment and CSR. But unfortunately, again, you see multiple sections. So CSCR can mimic many conditions, especially in elderly people. And that is one of the important indications for doing the multimodal imaging. So just earlier, we used to do only OCT. But now when we do all this multimodal, many cases of CSR are diagnosed as some other condition. Now this is another very interesting case seen by one of my colleagues. Now you see this one, again you see just patches of RP atrophy, everything marked beautifully in the chart. Patient is complaining of defective vision in the left eye. And then again, what do you see in this color photo? Quickly, what do you see in this color photo? RP atrophy, the patches of RP atrophy are seen in both the eyes, isn't it? Paramacular area, close to the fovea, there are patches of RP atrophy. Now you see the OCT. OCT shows, what does it show? Apart from the serous macular detachment, what does it show? Two things it is showing. It is showing a very thick choroid. You see the choroid? Very thick. The choroid, and the outer choroid is dilated, what they call as Pachy vessel or Haller's layer dilatation, etc. Okay, so serous macular detachment. So this looks like a central serous chorioret. All sections you see, there is not much abnormality in the retinal pigment epithelium, no irregularity, much, very little. Serous macular looks like a chronic case. Why it is chronic? Why it is chronic? You see the roof of the serous macular detachment, it is hyper-reflective. The roof of the serous macular detachment will be hyper-reflective and you will have multiple dots within the serous macular detachment, hyperreflex. Therefore, that means the fluid has been there for quite some time, okay? Now you do the ICG and the FFA, okay? Because why? You want to reach a diagnosis, whether it is CSR. What does the FFA show? Nothing much. It just shows some staining, right? You see in the paramacular area, there is little bit of staining, but nothing much. ICG, little dilated vessels. That is all. So, based on OCT and ICG also, it is a case of, looks like CSR. But since the patient is little old, we are not very sure. We are still worried. The other eye also showing a similar picture. You understand? Just some staining, no focal leak, which you see in CSCR, no smokestack leak, no multifocal leak, like what you see in CSCR. So, eye diagnosis could be a resolving chronic central serous chorioretinopathy. But considering the age of the patient, you see the autofluorescence also, increased autofluorescence can be due to fibrin also. You understand? It need, or due to RP dysfunction. So, but then finally we did an OCTA because we thought that it could be a CNVM because of the old. So, OCTA shows neovascular network. So, in elderly patients, we use multimodal imaging like this. So, although the other tests were not conclusive, we do the OCTA. Nowadays, we do it early. But what I mean to say is that the stepwise use of multimodal imaging in this thing. Okay, macular telangiectasia. Now, this is the last thing. Okay, now you see, now what do you see here in this picture? What do you see in this picture? Pigmentation in the red. So, parafoveal pigmentation, very diagnostic of mactal. And then what do you see in the left picture? You see one dilated vessel. You see the right angle vessel there? That side, I remember not probably in the photograph. So, this patient during follow-up, what happens? The pigmentation increasing, but other eye, little bit of fluid-like thing. You understand? So now the right eye, classic macular telangiectasia, but left eye has got serous macular detachment. You can see there, but there is an elevation of the pigment epithelium also, and he has got a neovascular network. You understand? So therefore, OCT is very useful. When you see the serous macular detachment, you are doing the other imaging technology, modalities, and actually this is a patient who is having underlying basically a neovascular network in a case of macular telangiectasia. Now this is my last case. Now the left eye. The left eye looks very normal. Right eye classic mactal. Left eye looks very normal on the photograph. But if you do the OCT, you can see one small area of ellipsoid loss. There are many causes of focal ellipsoid loss in the fovea apart from macular telangiectasia. You understand? Ocular maculopathy, so many conditions are there. Solar retinopathy. But using multimodal imaging, you can diagnose mactal in the other eye, focal ellipsoid loss, increased autofluorescence, parafoveal, very important to diagnose early mactal. You understand? Early mactal. Therefore, although photograph looking normal, careful OCT small defect, and in autofluorescence you can see this increased autofluorescence. For using multimodal imaging, early cases of mactal you will not miss. You understand? So, this is my last case. It is very useful in inflammatory macular diseases. Now, if you see this patient, you can see one small multiple yellowish lesions, isn't it? And if you see very carefully, you can also see some little bit fluid and also something red in color. Now, if you do the OCT, therefore you see, I mean, nowadays how diagnosis improves. So, you see the OCT. What are you seeing in the OCT? In the OCT, what are you seeing? Multiple hyperreflective material. Multiple hyperreflective material which is collected above the retinal pigment epithelium, and there is some degree of retinal, therefore this we call it subretinal hyperreflective material. It is seen in many conditions, but in this condition it's a sign of possibly neovascularization. So in an inflammatory macular disease, coexistent neovascularization can come, and that can be diagnosed with multimodal imaging. Okay, so we do the fluorescein angiography. You can see that area where there was little bit of hyperreflectivity, there is minimal leakage. You can see the leakage, and therefore this patient was treated with anti-VEGF injections. In follow-up also, it is very useful to see for recurrence. Now, if you see the left side lower autofluorescence, you see patches of decreased autofluorescence and surrounded by hyperauto. So the presence of hyperautofluorescence, especially in cases like serpiginous choroiditis and all, the PGI group has beautifully demonstrated how increased autofluorescence is a sign of activity. So in inflammatory disease also, it is a very useful method of application. So in conclusion, multimodal imaging has got a very, very important role to play in the diagnosis, prognostication, and follow-up of many diseases in the macula, and we should use it, titrate it according to each case. Thank you.
Thank you, sir, for bringing everything together. Sir, very beautifully demonstrated through multiple examples the value of multimodal imaging. So, yeah, please. Thank you, sir.